Perfect. All right. Welcome, everybody. Welcome to our second coffee chat. We are going to get started with our check-in question. What sport would you want to compete in if you're in the Olympics? This has nothing to do with like ability to do any of the sports, but if you had any athletic ability, which I do not, so that's why I'm putting this caveat here, which one would you want to do? We'll start with Claire.
Oh, so mine is a really weird one. It's the modern pentathlon, which is a summer sport, but it's based on what you would need to win the Napoleonic Wars.
Oh, cool.
So their 5 sports are riding horses, running, swimming, fencing, and I want to say shooting is the last one. So yeah, I think sometimes that I was born in the wrong era, although I would be dead if I was born into another era. But yeah, modern pentathlon is one I always like to watch.
That's cool.
Thanks.
Put down the list. Lindsay, you're next on my list.
I love this question because my husband and I have talked a lot about this, and we really think that we could be competitive curlers. So curl.
I can see that.
I at least want to try it, and maybe in 4 years we can make it to the Olympics.
Thank you. Mark?
Can you folks hear me okay?
Yep.
All right, I'm having some audio troubles here. Ski jumping.
Ooh,
I was
that's
thinking
a cool
of it.
one.
I would
Yeah.
like to-
I would just love to fly down a hill like that. That looks like a lot of fun.
Yeah. That one looks like fun. Thank you. Marty?
I think I would do the slalom skiing just because I met my husband skiing in the 60s. And so I'm not into snowboarding and all the more updated skiing. Being in my 70s, I would like to do something that was downhill, but love that opportunity.
Yes. Thank you. Lisa?
Yeah, so watching the Olympics, I think half of the people that participate are absolutely out of their mind. But if I was going to participate, being that I would also be out of my mind, I'd probably want to do something like the bobsled.
Yeah.
Is kind of almost looking for trouble, but or maybe the luge even, that's even worse, but something that's really thrilling.
Those are definitely thrilling for sure. Let's see, Joanne.
Good morning. What a great question. Sounds like there's some daredevils on the call. As a former figure skater, I guess I gotta say that's where my heart's always been. And gotta say, watching it last night was quite the thing to watch the women skate and what they're capable of doing. But if I was ever young again and that flexible and strong, that's where my heart would be.
I love that. Thank you. Jessie.
Hi, good afternoon, everyone. My favorite every time the Olympics come around is gymnastics. To me, it's just amazing how these people just flip around and do these crazy stunts. To me, it's like, I wish I could do that.
Exactly. And then let's see. I'll end on Stephen.
And you know, my first inclination is slalom skiing. I love skiing so much too, and got a little bit of a need for speed. So I would think I'd go that way, but the skeleton luge, that looks like quite a lot of fun also. I wish I could do gymnastics. I wish I was. And the more I thought about it, the one sport I've never played was hockey. And I really think I would be good at it if if a lid started earlier.
I can see that. Yep. All right. Did I miss anybody? Looks like Libby just joined. Give her a second.
Hi, everybody.
Oh, there you are. Hi.
Here I am.
If you could play any Olympic sport or do any Olympic sport, what would you do?
Really funny because my husband and I were talking about this last night, and we really think we would do well on ski cross.
Mm.
We think we would do really well on that. So that's what I would want.
I think you would too. All right. I think we got everybody. I think I would do bobsledding. It just looks so fun. Just,
Yeah, that's glorified sledding.
yeah, exactly. Exactly. Looks like a thrill. All right. Today, Stephen is presenting. Do you want to tell us a little bit about you?
Yeah, you
For those
can
that
see
don't
some of
know.
my potential Olympic sports right there.
Yeah.
Surfing was just added to the Olympics last year in the summers.
Was it really?
Yeah,
That was great.
South
It was a lot of
African
fun to watch.
woman won. Yeah,
Ah,
Look at that.
cycling. I don't quite have the lungs for that at the Olympic level, but skiing I would maybe be able to compete in. Hello, everybody. I'm Stephen Hoy. I am a member of the PFCC Partners team, but first and foremost, I'm a patient family advisor in a number of settings that I've had the pleasure of doing over the last few years of my young career. I do work with everyone from the Center for Medicare Medicaid Services, the American Institutes for Research, California Quality Collaborative, but my true favorite one is Mammoth Hospital, my local, I think it's 22 bed critical access hospital in Mammoth Lakes, California, my favorite ski location in the country. And I serve on their PFAC and otherwise. So, a lot of my work is around chronic pain management, just chronic disease management. My brothers and I had over 8 specialists following us 3 boys growing up. And I regularly refer to myself as a walking triple aim, which is a goal the health system's been going for better care, cheaper, and more efficiency built in. So that's just a little bit about me. I live in Long Beach, California. I was born and raised in Long Beach, California, and I've lived in Colorado for some time, Mammoth as well. Roger, hey. And yeah, make my way around, but in patient family advisory work, but always, like I said, working at PFCC Partners as well as a blessing that I get to do this full time. Most recently, we've been working on what is called the HQuick. If you're a fan of acronyms, it's the CMS. No, let me see if I get this right. It's a CMS IDIQ HQuick program. So Center for Medicare Medicaid is leading pays organizations to deliver technical assistance to hospitals around the country. And I'm blessed to partner with Cynosure Health, who has a network of over 300 hospitals in California, Colorado, Louisiana. There's about 9 or 10 states. Mostly critical access hospitals like my lovely Mammoth Lakes. Done some work. We've done some work around obviously COVID vaccine confidence. We've done, I worked on an affinity group for targeting provider burnout challenges, which was an interesting space for patient family engagement. But now we're looking at, the team is looking at some of the core patient family engagement priorities of the HQuick program. HQuick stands for Hospital Quality Improvement Collaborative. So those priorities are around admission planning, bedside rounding, discharge planning, and patient advisory programs, among a number of other like harm topics, including adverse drug events, readmissions is a big one. And I think obviously the biggest opportunity for patient-family engagement to have an impact, especially as we look at how we plan and coordinate discharges that are effective and keeping people out of the hospital. At the end of the day, the best hospital would be an empty one in my book. So they're looking to us to help build some criteria around those topics, tools around those topics now. And that's kind of what I'm challenged with this month at this time, is particularly admission planning, bedside rounding, and discharge planning. Admission planning, we're finding a lot of hospitals, I should also say, we just conducted an analysis, a survey of hospitals. We had 186 respond. And we learned a lot about where they think they are, where they self-scored. Some of those themes were that admission planning was admittedly the biggest challenge for hospitals, which I think makes sense given the environment today. Excuse me. Shockingly, they rated discharge planning the highest. So they say, so hospitals consider themselves strong in discharge planning, but the continuous improvement side of me says, I think every hospital could use a little updating to how they plan discharge with patients and families. So we're just digging into those first three and thinking about how we can help hospitals plan for admission, engage caregivers in bedside rounding and shift huddles, shift exchanges, and then of course discharge planning. Our theory is that it should be one journey. It should be one area, it can be one tool. We should be thinking about discharge planning at admission and covering some of those things during bedside rounding. Obviously, our hospitals are having a slew of challenges right now, and everyone who's still working in a hospital is a great person, given all that they've been faced with. So it's just an opportunity to update some of these things. As we've learned, they exist in the EHRs mostly. We've seen a handful of examples of admission planning is kind of where we're starting right now. And when I looked at some of the admission planning checklist examples from those few that said they had them, I wasn't too surprised that there were some what we call opportunities for improvement, OFIs, around there. Those checklists included things like checking for latex allergies, COVID vaccine screening, ads and things you can kind of imagine are in their social determinants of health screening. But there wasn't a lot of communication with patients and families, as like a check item that we need to be doing regularly for every admission. And that's kind of where I'm looking for help today on this call. Like, what are those things that a hospital should have included in those checklists that engage patients and families for safer admission? To me, some of the starts are hand washing protocols. There's the safety events like bed sores, pressure injuries, bed sores. How to screen for those if patients are at risk. But there's got to be more, like, everything down to where to park, to what to expect in family presence and caregiver presence. So I have a few resources that maybe we can look around, but I'm just going to start now openly. Like, has anyone had a recent admission or been a caregiver at a recent admission and had some thoughts like, wow, they could really do better about blank?
I think, one of the things is your medicines, your drugs that you take home. Because I was in the hospital in last February, and I had a major surgery done. And like when I brought in a list of the medicine that I take, daily. And they kind of didn't give me all the medicines that I take. For some reason, they left out a few. And it was like, well, I need my sleeping medicine at night, my trazodone, but they didn't give it to me. And I don't know if it was just because it wasn't on the list or, so I don't know if it was me not giving them the full list or if I should actually, they always tell you to bring in your medication. Well, I'm the kind of person that never does that. But, I try to bring a list in.
Yeah.
But I think things around medication. Also, when I was in there, I ended up, as soon as I left and got home, I ended up getting a MRSA infection. So, I didn't know at that time who I should call about it. So I called my physician and the doctor that operated on it. And he was like, well, okay. So I didn't know if I was supposed to report that to the hospital or not. That's the question I had for you
That's
all.
a good one.
But yeah, stuff around medication, infections. And I think it was aftercare that really failed for me. The aftercare component of it, because that infection got pretty bad there for a little while, and I was out for 6 weeks with MRSA infection. A rough time.
That's one of their stats.
Yeah.
And one of those things they look at often, and maybe a good example of where some better engagement would have helped avoid it. I like the follow-up actions if something's going wrong. Covering medication early. We had this thing when my grandmother was in the hospital. We were trying to get her ready for discharge, and there was a hospital policy that said they can't review the medication list before discharge. So we left the nurse in a place where she was like, had to slide it over to us and to see. So I think the use cases for some of this is like just as important as the domains too. Thanks, Roger. Good to see you.
Same here. Thanks.
I have a couple actually. They're a little bit not so talked about. Now, I haven't been in for a while, but I used to go in at least once a year. And I've recently had some discussions with other patients. One in particular that I can't really go into the details about, but let's just say it involves some blatant HIPAA violations, security being called, and heads of department not responding. So it would be nice that if you are having an issue with staff, where would be a place to call that would actually respond. I had issues with this in another state in decades before, and she just had issues with this 2 months ago. And then the other one that I'm thinking about is, especially if it's a new diagnosis, there is a lot of information that is not communicated to the patient in a timely manner. So for whatever the particular diagnosis is, where to go to get the basics, even something as basic as what broke inside my body to make me be in this position. I mean, to me, it's a little criminal that whoever is making the diagnosis and handling that first exchange doesn't take the 3 to 5 minutes it takes to communicate that, but it happens a lot. So if you have to go out on your own to find what's going on in your own body, it would be nice to have a sort of preset resources so you don't have to spend a ton of time on it.
I saw some of them I reviewed said they had 4-hour and 24-hour admission things to hit. And I think that's the
Right.
value of a checklist, is if we include some of these now communication pieces that patients and families are regularly missing, we
Right.
may stir up a lot of improvement just in communicating. I
And
saw
outcomes are better when you understand what's going on. Right.
Yeah. One in the 24-hour window was care plan applied. But I was, curious about how the communication about the care plan, the development of the care plan.
Right.
Was
And
done.
a care plan, the development of a care plan does not necessarily include the details of what the disease is. And I'm talking about something as common and basic as diabetes, right? This one particular person who I am supporting through her diagnosis, I thought she had the support she needed because it runs in her family and she had good folks around her. Call back a month later and nobody has explained to her, number one, how type 2 diabetes works. Number two, things like the A1C scale. She's freaking out because her blood sugar is 140. Really? Like, that's not okay. That's an additional burden to the patient when you don't have that kind of information, even on the most common stuff, let alone the less common stuff. So
Yes. I think the common stuff is the most often overlooked. What do you think, Lisa?
Yeah, I mean, this is all so relevant. I could just go on and on because, you know, this is kind of a huge part of patient safety. But I think hospitals really are very bad at communicating, and this whole thing with medications, it's a continuous problem. People don't know that hospitals have a formulary, and if it's not on their formulary, they won't give it to you, period.
Yep.
And you can ask very often if you could bring your own medication with you in the case that they don't use that medication. But people don't know that. I think that patients really need a handbook when they first come in, and that handbook needs to go into how they handle your medications and what you can expect, like a discharge list for the patient so that they can check off that they've gotten all the information. Because any transition, whether it's going into the hospital, whether it's from floor to floor in the hospital, or whether it's discharging, is wrought with errors and omissions and things of that nature. So the patient, as much as it shouldn't be on their shoulders, needs to be very, very actively a part of it. I mean, fortunately, I have not myself been in the hospital recently. Family members have, but it was probably now about a year ago. So we're having a good year from that perspective. I think that people also need to know if there's a problem, kind of what is the hierarchy in the hospital in terms of getting patient support? You know, what nurse on the floor is the first one that you ask for? Who's above them? Who's above them? Where does the resident come in? Where does the fellow come in? Where does the hospital administrators come in? You know, people don't understand that. They don't even know how many people are involved in their care. And they need to be explained the different roles of all these people who are going to walk into their room. And they need to know what their purpose is, and they need to be advised. Patients need to be advised through a proper introduction when somebody walks into their room, who they are, what their level of expertise is, and what they intend to do while they're there. To what was just said, people need to know what their main problem is, and then what else affects that or impacts that. As I don't know who it was who was just speaking, but people go in with fluid retention in their legs, and they don't understand that that's not their main problem. Their main problem might be congestive heart failure. So, you know, we're not communicating very well to the patients. There needs to be an intake, like, you know, like has been discussed, but not just for the purpose of the hospital. It needs to be for the patient as well. It has to go two ways, the communication. And most important is that the patient really has to be part of their care team. We can't keep saying we've got patient-centered care when it's really patient-focused care, where everybody else is making decisions that they think are best for the patient, but the patient's not actively a part of those decisions. So I think the intake process needs to be changed in many cases. I think that the patient during the stay needs to understand how the hospital works, be it through a manual, and the manual needs to be presented in different formats. Needs to be audible, maybe a video and a book, because people learn in different ways. And then discharge, my goodness, so many things throughout my experience. And I imagine that in your family also, with all the different experiences that you've all had, discharge is where things really fall apart because there has to be follow-up. And the most important thing at discharge, I think, on top of all the other very, very important things, is patients need to have somebody to contact at the hospital, not contact your primary care doctor who wasn't there the whole time, but somebody at the hospital who can access your hospital record to answer questions that you may have when you get home. Because then hopefully you're feeling a little bit better and all of a sudden it's occurring to you what you didn't understand was going on. And I've taken up enough time. Thank you so much.
Invent it now, please. We could need this. This is our opportunity to change it in 300 hospitals. So I see Marty up next, but I also do have a tool we're working on that maybe we can update, has some of these things. I'll pull that up next, but I'm sorry, my camera also went off and it says cannot connect anymore. But I'm still totally here.
Stephen, we've got Marty and then Nancy Brockerman queued up for.
Thank you.
So we'll go to Marty first.
Heave it up. If you've started
Marty?
spewing wisdom already, Marty, you might be on mute.
You are right. I am on mute, Steve. I apologize. Lisa hit on a number of things, but the biggest question that patients always have is who's in charge? Who's my real go-to person? Particularly because when people come into the hospital, in many cases, they have a hospitalist and they don't have their own doctor that they're familiar with. So if that makes a big difference, we have put whiteboards in the room to try to designate what each role is and what the name of the person is so that could at least be helpful for identification. Lisa covered most of the comments about them coming in. When we talked about medication, the medication list is really great, but the main thing about the medication list is, does the patient have the medications and does the patient's pharmacy have the medications that are ordered? I've had many patients that have gone home with scripts that their pharmacy didn't care. That is literally a painful experience. So we want to make sure that connection is there. Another thing is that we did a lot of what we call day after discharge calls when I was doing a lot of oncology work, and you would be amazed at how many glitches were found when the patient was called the day after discharge by not necessarily a high-level person, but a healthcare provider that knew what was going on and had an opportunity to connect with the people that might need to be brought in for reaffirmation. And you cannot do any of this without family presence and a care partner, because we as patients, when we're in that environment, are not working at full speed. And so that family presence issue that has come up so much since COVID-19 has started really has been detrimental in the emergency room, in the inpatient. I just know now that our inpatients are only allowed one person. And they're, the hours are from 12 to 9. And that doesn't always work. First of all, it doesn't work well for the patient, but it doesn't work well for the staff either. And if you're getting ready to do discharge or doing any planning or decision-making, it's unfair to the whole healthcare process not to have the patient have their care partner with them. So I think I'll stop at that quick list and see what else is up, and thank you.
Yeah, I'm with you. I think I wish for a COVID-19 world that somehow, yes, visitation went away, but care partner engagement could have gone up.
Exactly.
Virtual uses or otherwise. I think we bundle caregiver engagement in with visitation too often in these hospitals, and a little bit more guidance on communication would be super helpful. I lost track of who was next, but fire when ready.
I think Libby said Nancy Bruckerman had her hand up. Nancy, you might think you're on mute.
Has anyone heard, well, Nancy figures that out. Has anyone heard or had experience with like good caregiver engagement with family members in the hospital, particularly when, you know, that shift exchange or rounding opportunities? Have we seen it done well anywhere?
So, you know, I go back to my visit there in February. And we had, so when the nurses came in, they were really nice. I think the whole experience was made better by the nurses that came in. They identified who they were. They told me what they were doing. Very, very gentle. And, you know, this was during COVID. So, well, we're still during COVID, but, you know, the COVID was going on. So they had their masks on and made sure everything was sterile. And, you know, I had a really good experience in the hospital with the nurses, though. They were very nice.
Steve, it's Marty again. I'll just say that if the hospital doesn't make it an expectation that they're focused on the patient and all of the things that we work so hard for all the time, even in the best of hospital environments, you can have a not so perfect experience. You can have a negative experience. And it works the opposite way as well, that you can have, in spite of the fact that everybody else has a terrible experience, you can have a provider or a team that does follow through and follow all of the guidelines that we think are important. So I, again, always go back to, if it's not from the top down and if it's not from the expectation, none of it is going to happen in the patient experience.
Thank you guys. This is so helpful. I'll share my screen now, Laura. So is there, let me think. So we're on working our best to capture a lot of this, and this is just our working document, so it's not gone to anybody yet, but we do, you know, I keep telling myself we have these handfuls of hospitals who maybe just need the prompt to update their EHR to include some of these things as checklist items so that they happen regularly and for every admission. We're not counting on that star leader or otherwise. It also gives organizations an opportunity to see, you know, where they're not hitting the mark, you know, in their natural processes. You know, we can sit with, if we implement some of these checklist items, such as discuss the need to be admitted, is kind of what we were talking about this at the kickoff. You know, why are we here, and cover the diagnosis and all that. Discuss the process for admissions. You know, I think ever important too is the patient privacy and Bill of Rights. You know, and oftentimes that Bill of Rights can be handed in a way that doesn't quite activate or engage patients in their hospital stay. So how can we tweak that language, or you know, any of these other topics, so, you know, hospitals are more regularly doing this stuff at admission?
Stephen, can you increase the size a little bit for some of us with older eyes?
Thank you.
I'm gonna go actually down here. Sorry for my. So I don't see the medication one yet. We'll definitely make that a a new field in here. And again, my dream is that this connects, these domains will also come up when we're doing shift exchange huddles. And then again, when we're discharge planning.
I have a question, Steve.
I don't necessarily have an answer, but you can try.
That's okay. So, I mean, and now with COVID, so some things have changed in the hospital that weren't there before with the masking and protection and all that good. So should there be something in here that says your COVID instructions for while you're in the hospital?
Yeah.
Good point.
Expectations.
Yeah. There was a thing that was done by Pat Merriweather. I don't know if you guys, I'm sure you know who she is. Yeah. So she did a thing on a whole like list of things, the questions to ask if you're going in for a surgery or something like that. And it came up with a whole list of things that was really a good document. So I don't know if you might want to reach out to her. But yeah, something with COVID and what to expect. What are your expectations? What are their expectations around that there?
Looks like Nancy's available now.
Floor is yours, Nancy.
Can you unmute me? I was moving the mouse to get to it, and now your agenda is covering up where the icon would be to do that.
We can hear you now. Oh, how'd you?
There you go.
Hello again.
There we
I
go.
already had written a few notes to myself, but then I was looking at the agenda list and saw question number 7, orientation to new floor. It took me back memories, and these are 11 years ago when my dying spouse was in and out of the hospital. There was a time that he was being moved from one floor to another, some areas acute and some not so acute. And consistently, he knew how to work the gadget that they gave him to get to the phone, the television, and so forth. But as a family member, I found that every little supplemental room where you could heat up a snack for yourself had different kinds of microwave ovens for making your snack available to yourself. It's trivial, but certainly at the time it was a nuisance. The horror story we had with one of those discharges involved medications, and I'm not sure this is one of the things that brought me into this kind of caring about hospitals and medical in general. When he was ready to leave, he had 7 scripts. And when we went out the door, I think they called, I don't even know if they had an advance information to go to the pharmacy. I suspect not, but we went to our quote unquote favorite pharmacy, one of the major chains, and they had some of the 7 available. So they did a little calling and found out where we could go to another one. So we got more, and then we still had to go to a third pharmacy. Along the way, we lost the fact that one of the things that he was supposed to do was to have a heavy dose of probiotics, but being over the counter and not prescription, there were no instructions. So we kind of used that rather lightly. The whole story ended up with an unhappy ending, but it was certainly a learning experience. Something tiny that I think was in Lisa's list or Marty's of people introducing themselves when they enter the room for the patient. Have the name tags visible enough with big print. I'm somebody who these days has good distance vision, but I have to grab for the reader cheaters from a decision that I made with my cataract surgery. So, and if you don't have your glasses on, and you probably don't when you've been napping in the hospital bed, it really helps if you can know who it is and you don't have to ask them their name, especially because some people might be defensive. Oh, you're going to want to report me? Why do you want to know my name? So that's my comments for now. And I'm glad I can see the screens and be a part of this.
Me too.
So Stephen, this is Lisa. I just want to quickly jump back in. I think it's critical for anybody who walks into the room to verbally introduce themselves and their position, because there's just too much going on for patients. They're hearing a portion of what's being said while they're there, or at least they're registering a portion of it only. And it will make it so much better if they can get that much better of a sense, and who's who and what they do is very important, because then you can sort of figure out too who to address with issues that you want to discuss. And towards that point, I mean, you really do have to know how the structure of the hospital is set up. A small hospital will be entirely different than, you know, a Yale New Haven health system hospital. And it's critical to kind of have a feel for that. The other thing is that, as maybe it was Libby who said, visitors are not just visiting, they're helping. And I think it's essential that we try to communicate to hospitals that there are ways to allow people with the patients, especially what happens with people with disabilities. I mean, and not necessarily obvious disabilities. So I've heard way too many times of hospitals having policies about not having anybody with the patient at admission unless it's medically necessary. But there are other reasons, in a sense, why it's medically necessary. And people don't know that they can say, well, this person has mild dementia, but doesn't know anything about their care. Or maybe they don't have dementia, but they're a senior who just doesn't engage and get involved in that way, because not everybody's involved in their care. We need to allow for a vast majority of different types of people, and they, you know, who are coming into the hospital, and provide them the support that's needed. Or what about, we've had a situation with an elderly Spanish speaking woman who the hospital insisted be left at the emergency room by themselves. And sure, they have translators, but it's not the same as somebody who knows, who's involved in their home care.
Mm-hmm.
So I just want to say that we're allowing for so many breakdowns, and communication, as most of us who are involved in healthcare, probably everybody on this call, communication, we recognize, is the leading root cause of all errors and breakdowns. So we really need to focus on that.
Absolutely.
Yeah, I find almost all of my topics have been, you know, all of the work going into updating these admission and discharge planning is on communication. It's not, you know, it's a few things like checking for latex allergies and medications, but a lot of it is just communication. And I think that's easy, you know, it's not too hard to communicate. It's, you know, it's not rocket science. Otherwise we would have done it already. And, you know, so I'll just go stop there. I think I heard somebody else.
Steve, it's Marty again. You had the rounding situation up there, and what is rounding and who is rounding and all of that. We did do a pilot and actually created a best practice at Brigham and Women's with the bedside rounding through IPFCC in our GMS department. And bedside rounding really alleviates a lot of the misunderstanding if you have the patient and the patient caregiver included in the rounding. They did find they went up against a lot of, no, we shouldn't do this, it takes too much time. They actually found when they participated in it, it was usually our hospitalists, that it decreased extra calls. People knew where they were at. It increased patient satisfaction. It decreased length of stay because everybody was on the same page. There were a lot of positives. And I think, unfortunately, the COVID has gotten in the way of that, but we should start bringing back what is bedside rounding and how can it work in your environment to make sure that everybody on the team is on the same page and that your patient and their care partner have a true understanding of what is to be expected and who they might interact with if they had a question in a certain area.
Absolutely.
Stephen?
We made that recommendation in Mammoth Hospital as a PFAC, and it was a funny example of why working in small and rural hospitals can be so much fun. The PFAC recommended we should do this all of the time, and while the facilitators of that PFAC were going and getting approvals from the board of directors and otherwise, the floor managers got heard that we recommended it and just went ahead and implemented it because it was on their floors. And they thought it was a good idea. And lo and behold, yes, taking the time to have some of those conversations, alleviates a lot of the challenges in hospitals. Go ahead, Libby.
Thanks. I just want to clam onto that comment, Marty, and I'm so glad that you brought that up and that the project that you did, because one of the things we saw in the assessment is that bedside rounding is, reportedly pretty high across the board. And so this concept of then how do you connect what you learn in that admissions, pre-admission process? We're moving away from the term checklist because we want to bring a bunch more stuff into it. But how do you take what you learn about the patient's priorities and values and contacts and care partners, bring that forward into rounding, and then have that rounding conversation be talking about discharge every day?
Right.
So we're really wanting to kind of connect those processes, and I'm curious what you think about that.
They definitely need to be connected, but again, it has to come somewhere in either the floor or, like Steve just said, the nursing manager or whoever's in charge. And if you happen to be in a teaching hospital, that has to go through the attendings and get them on board. If you're in a local hospital, whoever's, I'll use the phrase, the big cheese in the process. But if you don't have that buy-in from them, and we all know that the staff has to be trained on how to work with us crazy patients and what the expectation is, as well as we have to give the patient and their care partner a little bit of heads up is, you're part of this team too, and don't be intimidated. So there's a little more that goes into it than just dropping everybody in the same room. They got down to each person that was at the rounding at Brigham had a certain spot around the bed, and that's where they were every day. So you all had your little position with the patient and the patient's caregiver at the head of the bed. And usually the gentleman or the person in charge would be at the foot of the bed, and the conversation would go, clockwise or counterclockwise.
Fascinating. Thank you.
I just have a follow-up comment on that. Or I have a comment. So when I was in the hospital and after I got my surgery and everything, and I was pretty out of it because I was on meds, some pain meds. And when they came in and they did their roundings and the doctor came in and talked to me, I could not for the life of me remember what she said when I, woke up from being, drugged out. So I think having a caregiver or your partner or whoever there when they do their roundings is a very important thing. But you never know. You're really not sure when they do their roundings. So it's like they should have a schedule of when they do their roundings. So I could have had my partner there at that time to hear what was going on. It was a little confusing.
Even call in, right? Like even get them on the phone.
Yeah.
Nancy, I saw your hand up.
Steve, I just want to say it's a little bit simple, but any patient can take out their cell phone and say, look, my memory is not going to serve me well. Can I please record this conversation? If a hospital objects or a doctor objects, they're they need to be spoken to try to explain why.
I
Well
like
said,
simple
Lisa.
solutions. I like simple solutions.
Am I on?
You're on that.
Couple of things. I love the phrase of who's who and what do they do. That helps a whole lot. My more recent experience with hospital has been with my significant other. I'm not a wife, but I'm very much involved. And this was with the Veterans Administration rather than a general medical hospital for the, and this happened during pandemic. When we made our first visit for something, I was confined to the waiting room. And so we left with medications and some other words that we didn't know what the things were because there are some memory issues. So 3 days later, we were there again, and I got a little bit pushy, and we're able to get more information, or maybe the person in charge or the provider that was attending to him was taking care of things. And then we had a few more weeks and something else was going on. And in fact, we had 2 trips for one purpose because they were so shorthanded that night and the waiting list was so crazy, and probably some people were home themselves due to the COVID issue. But I am, as the on the legal side, I'm the second person for power of attorney. I'm the backup person. The first person being a long-term dear friend who at sometimes during the week, she's very involved with her job and she wouldn't be able to come in. So we had to get it made clear by the social worker that I was authorized to be with him and hear what a doctor would say about the x-ray shows this or that or the other. I think we got that one solved, but it sometimes it can be frustrating, there's no doubt. That's it. That's it for the moment.
Oh, thank you. Got a few more ideas for our checklist. Of course, we'll what you're looking at is a very a drafty version that'll go through many iterations of and conversations with people like yourself and our team. And we'll be sure to circulate this back out once we get it to somewhere we're happy with. But we have time for a few more if there are any.
Just a quick comment. I'm looking at the list of the 1 through 6. I, a few months ago, presented a list to my friend's primary provider, and there were a lot of very specific questions, but the final one was, how fragile am I? Because at that point, we were 2 to 3 weeks away from his hospital journey. And the doctor really didn't quite answer. It was like, and that's where we were. So that's a useful question. If you end up with this uncertain, okay, well, I know I should take this pill 4 times a day, not twice or whatever, but you know, how fragile am I? And of course, this hints, gee, I might die in 4 weeks if I don't do something right. So it hides other concerns, but I think it's a good question.
Most important ones, yeah. You know, one of the most shocking readmissions programs in hospitals I've seen in the last year started providing medically tailored meals. Medically tailored meals by a 5-star chef out of the hospital, and they found the readmission rates dropped 33%. A third of the people stopped coming back to the hospital if they were providing medical meals for 2 days when they left.
Mhm.
Testament to how we often overlook the core needs of people. Well, cool. Thank you guys so much for that. That is so helpful as we get started on our journey to help hospitals with this. I know it'll reach at least 300 hospitals, but maybe even more. So a serious opportunity for our team, and that I'm certainly be proud to be an advisor for. So I have you guys to thank for all your help on this. Of course, this is what we want our coffee chats to be going forward too. If you ever have work you're on, questions for advisory groups, this is a nice, comfortable place to do it informally. I'm sorry my camera went off. I was really proud to show off my freshly grown mustache, Roger.
That's fun.
And just another thank you guys. Yeah, I think Laura, did you have anything else, or are we closing out now?
It was just the you said it, if you're interested in doing what Stephen did and bringing an idea or a project or anything to the network, to this coffee chat, I'm going to put a link in the chat. It's just an interest form so we can get some more information and on your ideas and things, and get a little bit prepared before doing this, the coffee chat. But feel free to fill that out and we'll get in touch with you with any questions that we may have, and we'll get you set up to present on a future coffee chat. Any questions?
I certainly enjoyed my coffee with you guys today. Thank you for a great Friday.
Same here.
Thank you.
Yeah.
Thanks, everybody.
Enjoy the weekend.
Cheers, you too.
You too.
Wonderful
Bye
weekend,
all.
guys.
Have a good
Take care.
weekend.
Bye.